about our recent experience with one of our patients who was on prolonged ECMO, and to help you all understand kind of what we did, why we were doing it, and what was the hope with instituting these somewhat experimental therapies. And so I'm going to go through 3 of those therapies today. One of them is sodium bicarbonate. The second one is going to be inhaled TXA, trihexamic acid. And the third one is the one you're probably most excited to hear about, which is perflubron, also known as Liquivent. But before we do that, let's start from basics. So what we're discussing today is the use of veno-venous extracorporeal membrane oxygenation, VV-ECMO, for the treatment of patients with pediatric acute respiratory distress syndrome, PARDS. So we need to understand the definition of PARDS. In 2015, the Pediatric Acute Lung Injury Consensus Consortium, also known as PALIC, came out with this tabular definition of PARDS, which is specific for pediatrics, and it differs from adults in multiple ways. The exciting thing is, until 2015, we really didn't have an operational definition for ARDS in pediatrics, and so we borrowed from the adult literature and applied it like we do for so many things. But this definition was actually tested by a clinical trial that we were a part of called PARDI, Pediatric Acute Respiratory Distress Incidence and Epidemiology, one of the first clinical trials that I participated in, and validated some of these definitions. And now these definitions are being used in another clinical trial and in basic day-to-day general management of these patients. The clinical trial that's being used most robustly in now is the PROSPECT trial, which we're also a part of. So really, it's great for us to be a part of these trials because really we were involved in validating these definitions. And in validating these definitions, I hope we've also learned them very well, and they've become a part of our clinical repertoire. So PARDS is defined in a pediatric group, excludes any patient with perinatal-related lung disease. The timing has to be acute, within 7 days of a known clinical insult. Edema is allowable as long as that edema is not from cardiac failure or fluid overload. So this edema is allowable if it is a result of capillary leak leading to ARDS, PARDS. The chest imaging findings are different from the adult studies. The adult studies say, or the adult definition, the adult Berlin definition requires bilateral infiltrates. But in pediatrics, it only asks for a new infiltrate consistent with an acute pulmonary parenchymal disease. And then the next addition that's really important is that it allows for patients that are on non-invasive mechanical ventilation to have a diagnosis of PARDS. And so patients that are on CPAP or on full face BiPAP who have P to F ratios or SF ratios qualify in having PARDS. There's no reason that they should be excluded because we learned from our trials that those kids are just as much at risk of decompensation as their invasively ventilated counterparts. And so when you look at invasive mechanical ventilation, what we have to diagnose PARDS is what you guys are now very astute in determining, which is the oxygenation index or the oxygenation saturation index. Now, whenever you have the word saturation in there, it suggests that you can use, instead of the PaO2, which is only derived through an arterial blood gas, you can instead use the saturation. And so several studies out west at CHLA have validated the use of SF ratios and OSIs compared to P to F ratios and OIs, and they are very comparable. And the important thing is that since we can use the saturation, we don't have to have an arterial line in patients. And so this definition then is much more inclusive of patients that have the underlying condition. Special populations that include the cyanotic heart disease population, the chronic lung disease population, and any child with left ventricular dysfunction. Now, suffice it to say that right now, these special populations are inadequately addressed with the current definitions. In fact, in the PARDI study, the cardiac arm had to be thrown out because of lack of enrollment. So we really can't talk about these special populations. And so we're really talking about patients without those conditions that come in with this acute onset respiratory failure with these indices that you have that you can measure readily at the bedside and manage them very, very closely from the minute that they enter your hospital. There's really no reason that you cannot identify their degree of PARDS because you know how to calculate these. The P to F ratio simply is a PaO2 over the FiO2, which requires an arterial line, but the SF ratio is simply the SAT over the FiO2. Similarly, if you have a patient that's mechanically ventilated, the OI is the PaO2 times the mean airway pressure over the patient's FiO2. And this OSI would be the same, except you substitute the PaO2 for the SpO2. And this is how I'm hoping we are managing our patients and thinking about our patients that have acute respiratory distress syndrome.
The specific disease process that Prospect is investigating is pediatric acute respiratory distress syndrome, also known as PARDS.
Oops, sorry about that. So PARDS overview. Pediatric acute respiratory distress really takes a long time to go through its entire cycle, right? The initial phase, the edematous exudative phase, can take on the order of 48 hours to 72 hours. But then there's a transition as the lung goes through inflammation, and then as it sets down hyaline membranes, as the inflammation subsides and it begins to put down fibrotic tissue. This can take upwards of several weeks. This overview here just kind of breaks it down over a 7 to 10 day period at the best case scenario. But on the right panel, what you're seeing is kind of how that inflammation leads to ARDS. If you look at the proliferative phase, you see lots of different inflammatory cells like the M1 macrophages and neutrophils, and all of these things that are elaborating inflammatory markers like STAT6, MMPs, interleukins, TGF beta. The point is that our own immune system is responsible for the edematous and inflammatory changes that take place and lead to pediatric acute respiratory distress syndrome. And the fibrotic phase is really the resolution phase, when things are getting better, the body starts to put down fibrotic tissue in an effort to heal all of the damaged tissue. Suffice it to say, though, that PARDS is not something that comes and goes, right, in a very short period of time. It should come and it should go, but it takes a certain amount of time. So whenever you have a definition of PARDS in your mind, that this is going to take at least a week to 10 days to start to show signs of improvement. And so our job during that time is to support those patients and to take care and protect those patients. And how do we protect those patients? Well, we institute lung protective mechanisms of ventilation, which Prospect directly addresses. We limit their FiO2. We limit their mean airway pressure and their plateau pressures. We max or optimize their PEEP based on the PEEP FiO2 grid. We do all of these things to try and re-recruit the lungs, keep them open, but keep them in a rested state, if you will, to prevent either ventilator-induced lung injury or to prevent things like atelectotrauma or barotrauma or volutrauma. So what about ECMO in PARDS, right? So overall, in the ELSA database, there's about 7,500 children with respiratory failure that have been supported on basically mostly VV ECMO, with a proportion of them on VA ECMO. The survival rates of these patients is about 67%, and survival to discharge is about 60%. Okay, so it's a condition wherein if a child gets to that point, you're already thinking that their chance of survival is down to 60 to 70%. The number of pediatric patients on ECMO has risen from 2003, only 200 patients at that time. It's come to about a little bit more than twice, up at about 500, although we've gone a whole decade. So even though we've adopted the usage of ECMO, we've learned more about it. It isn't as though our usage of ECMO has skyrocketed, because there are very serious and significant side effects, or complications, not side effects, complications that can take place with placement of a patient on ECMO. Now, etiologies, as you would imagine, are mostly infectious, viral, bacterial, aspiration related. And those patients that have viral-induced acute lung injury and ARDS that go onto ECMO actually have the best prognosis and the best survival, and their survival is about 68%. ECMO and PARDS, more about that. There's grade 1 level evidence in the neonatal and adult respiratory failure populations, meaning that it's very good evidence showing that in those patients, they do fairly well, and there's good indications for ECMO in these patients. But in the pediatric age group, there isn't. There are only case series and case control studies in pediatrics that we are using to guide ourselves and to guide our management on how and when to place these patients on ECMO. So there's no real published guidelines right now for inclusion or exclusion of patients that have PARDS onto ECMO. Now, Prospect provides some guidance. They talk about if you're in the trial, if you have a 4-hour pattern of failure, in the management arm, then you can consider ECMO. They don't actually prescribe ECMO. They say you can consider ECMO. And that 4-hour pattern of failure is if you're desaturated, SATs less than 85%, despite an FiO2 of 100%, maximize with maximal PEEP based on your PEEP FiO2 grid, or if you're on the high frequency oscillator, a mean airway pressure of greater than 35. And conversely, that's oxygenation failure. If you have ventilation failure, pH less than 7.15, despite a PIP of 32 and above, which is detrimental to the lungs, right? And maximal rate without air trapping. Or if you're on the oscillator, a very low hertz under 8 or a very high amplitude above 90. So all of us can recognize that those are some very, very high vent settings, and that anything within those ranges, you should start thinking about the fact that ventilation isn't working, and continuing to try to ventilate those lungs is really adding injury on top of what's already going on underneath. Duration of ECMO is another good question. How long is too long? So really, we're trying to wean, whenever we place a patient on ECMO, right, we're trying to wean them as soon as lung recovery has occurred. But when does lung recovery occur? There's no one single time point that we use, or an index or a clinical index that we use to determine if lung recovery has occurred. Sometimes we're lucky because we begin to see recruitment. We begin to see that on rest settings, the say a PIP of 20 over a PEEP of 10, you're beginning to see more tidal volumes. And that's few and far between. More often than not, we are pushed to kind of pull the trigger with recruitment when we believe it's been enough time, right? So what's enough time? We don't know, right? I spoke about PARDS a few slides ago and said, looking at 7 to 10 days at least. Consider a patient that comes in, gets ventilated, and then gets put on ECMO. That's going to take about 2 to 3 days, potentially, to get them on ECMO. And then you're considering another 7 days of ARDS, and that's about a 10-day period already, right? So what does that mean for a patient on ECMO? So survival in children on ECMO support for more than 7 weeks was not different than 2 weeks. So if you're from 7 days to 14 days, your survival wasn't significantly different. But anything more than that could be detrimental. So a large case series in patients that had acute respiratory failure, pediatric, that were on ECMO showed a significantly better survival for patients supported for less than 14 days than those requiring more than 21 days. So really, we start thinking about prolonged ECMO duration when you're going up to about 3 weeks. And by that point, we need to start thinking, what can we do differently? Because look at the survival. It's down to 40% now, right? Remember, survival to discharge was 60% if you had PARDS and were placed on ECMO. It's dropped now to 40% if you have been kept on ECMO now beyond 3 weeks. And it stays within 60% if you're within 2 weeks, okay? So that's,
Sid, is there any data or anything about as far as like from the time the patient's admitted to the time that they go on ECMO? Does there seem to be any correlation with that? Like as opposed to longer as opposed to a shorter amount of time?
There is. In fact, the short answer here is that the quicker you get the patient on ECMO, the better it is for their survival. And the reason is, the longer you take to get on ECMO, consider the damage that's already taking place to the lungs. So if you have good guidelines, right, good guidance on when to get a patient on ECMO, you should get them on ECMO. And those guidances really have to do with kind of what I showed prior, which was what the prospect was talking about, right? The inability to oxygenate despite maximal settings and inability to ventilate despite maximal settings. If you're there, you should get the patient on ECMO. And I think in our center, we do a pretty good job of doing that in most instances. Sometimes a patient kind of smolders. There was a case last year, 2019, 2020, influenza B, trisomy 21 patient that eventually died. And she was a classic case of someone that was placed on ECMO late. So she had been on BiPAP, okay, for 2 weeks, I want to say, with very high settings, following which the trigger was pulled to intubate, remained on high settings for another 2 weeks, and then was placed on ECMO. And I think she was on ECMO for at least another 3 weeks before the parents withdrew. And multiple times I approached the family for prospect, and they declined participation in the study. But unfortunately, that's too long. The patient already had PARDS when she came in. In those 2 weeks of BiPAP, she had PARDS. I don't think we were following the P to F and SF ratios as closely, and I don't think we're very good at doing that. When a kid is intubated, we're great at OIs and OSIs. When a kid is not intubated, we're not paying as close attention to the P to F and SF ratios. And I think that's somewhere that we can make an improvement. And that kind of addresses the question you just asked. Because if we had seen the P and S ratios being really, really low, and we can diagnose a patient with severe PARDS, we may have intubated the child sooner, seen that the lungs are really non-compliant and sick, and potentially placed the patient on ECMO sooner. Would that have changed outcomes? I can't say, okay, because the child did have pulmonary hemorrhage in association with flu B. But in general, the earlier you place a patient on ECMO, the better they fare. Because if they have to go on ECMO, their lungs are sick enough. And so you're basically allowing for the lung to rest longer than kind of trashing them before putting them on ECMO.
Thank you.
So I think these numbers are helpful to us when we think long term, and when we're thinking a kid comes in, what are the indices to look for before thinking about severe PARDS? And in severe PARDS, what are the things to do? Neuromuscular blockade, for example, prone positioning, PPAP-IO2 grid. And if these things fail, placing them on ECMO. When they're on ECMO, what's the duration? You've got numbers like, 60% survival if we're within 2 weeks, beyond 2 weeks, 40% survival. And so those numbers really help guide us, help us guide the family, and help us kind of guide our own management when the kids are on prolonged ECMO. So we had a case of a patient that was on prolonged ECMO. She was a trisomy 18, correct me if I'm wrong, and had para-influenza and was placed on ECMO. I remember having a discussion at critical care rounds, chronic care rounds, to determine, what needs to be done. We were like 10 days in or something. And we all kind of discussed that, until about 2 to 3 weeks, it's going to be difficult to say what to do, because the lungs are going to remain de-recruited in this state. They need time to rest. The inflammation needs to quell. PARDS need to take its course, and then we can start re-recruiting. However, we came to about the 4-week mark. I remember pretty clearly that there were multiple providers on not having a clear path moving forward, because we were getting into uncharted territory. And you can imagine, when we don't even have indications on when to place a patient on ECMO, we have even fewer indications on when to take them off ECMO and when to determine if ECMO has failed. Because if ECMO has failed, that means we're at the last straw. The child has to basically be withdrawn from support and allowed to die. And we're not very good at doing that. And that's very natural and it's very understandable. And sometimes we try and rely on guidelines or other people or other experiences to help us. We didn't have any of that. So we had to figure out what we were going to do. We had to at least come up with an action plan. We also had a parent that was very invested and wanted to do everything there was available before calling it quits. And so we began to get into the therapeutic adjuvants for lung recovery. We couldn't safely do things like lung recruitment. We had failure prior in a different patient on prolonged ECMO who underwent multiple bronchoscopies, underwent multiple repeat episodes of pulmonary hemorrhage that could have potentially taken her life. Thankfully, it didn't. And so that experience made us hesitant in using those therapies, and for good reason, because those are very detrimental to the lungs. Consider before ECMO trashing the lungs with high PEEP. Consider on ECMO trashing the lungs with repeated bronchoscopies. We don't want to do that. So what did we have left? Fortunately, I was privileged to be on service during that time, and the ECMO specialists, as well as the bedside nurses, wanted a plan. And so I came up with a graded approach to addressing this with some degree of literature backing and some degree of my own kind of scientific assessment. The first thought was to institute something that was the least invasive and had the highest potential benefit, but potentially also would have the least amount of dramatic effect. Okay, so that's the first thing I'm going to talk about. Sodium bicarbonate, of all interesting things. We have so many things that we instill down the endotracheal tube, and why don't we do sodium bicarbonate? And that's a great question that I am also asking after my own experience with this child. Now, I don't know if I can say I saw clear benefit, but there is biochemical rationale for the use of sodium bicarbonate. And so why not have this in our toolkit when we're trying to do things from the get-go in helping to clear lungs out of debris and mucus? So how does sodium bicarbonate work? So this is a CF paper written in 2010, I think. Bicarbonate was hypothesized to be critical in the formation of normal mucus. Okay, how? So the data in this paper indicated that bicarb reduces calcium concentration within Okay, so mucus is made up of proteins called mucins. Mucins are held together by calcium. That calcium is potentially chelated or sequestered by bicarb. And in doing so, the mucus and mucin loses its integrity. So that's what the data was indicating in this paper. So reducing the free calcium concentration and decreasing the amount of calcium that remains associated with mucins led to overall mucin swelling and hydration, reducing the cross-linking of those mucins and decreasing its viscosity, allowing it to be readily suctioned out. Okay, bicarb can also function as a chelator to disperse the aggregates of mucins to make them smaller so that they can be claimed easier. And so taken together in this CF paper, they learned that poor bicarb availability in the context of cystic fibrosis could explain why in those patients secreted mucins remain aggregated and more viscous, and thus the affected organ remains under so much pressure. Can you excuse me for one quick second, please? Can we please close the door? I'm in the middle of a concentration. That's fine. Thank you. You've got that recorded for posterity. All the benefits of being at home. So that was kind of a brief on sodium bicarbonate. So I thought, why not start instilling this into the lungs of this child that is completely collapsed and seeing if it can give us some benefit. Now you can imagine that it doesn't have much detriment to it. All you're doing is instilling the sodium bicarbonate down and removing it. That's all you're doing. So suctioning is the only detriment that the child might face. So that was kind of the first phase of how I wanted to move forward. The second phase was inhaled TXA, trihexamic acid. So now TXA, the mechanism of action is that it blocks plasminogen. Plasminogen is a precursor to plasmin. Plasmin binds to fibrin, and together these have a fibrinolytic property. So inhaled TXA is supposed to fibrinolysis and thus prevent hemorrhage from ongoing so that you can actually build the fibrin matrix. There's several papers that I've thrown up here. Inhaled TXA in hemoptysis treatment, a randomized control trial, nebulized TXA for pediatric hemorrhage post-tonsillectomy. And then another observational study that I thought was very informative, especially in what we were doing, which is a third paper from Critical Care Explorations, wherein a retrospective study from 2011 to 2018 studied 19 cases of pulmonary hemorrhage. Not many. And 18 of those cases actually found success. So really, this is an observational case series, if you will. What they used was 250 to 500 milligrams every 8 hours of nebulized TXA given over a 20-minute period. And the solution concentration was 100 milligrams per ml. And they found that TXA was safe, and it safely treated pulmonary hemorrhage from varied etiologies in critically ill patients. So we only had this experience of 19 patients to go off of, plus some of the things that we can conjecture from the hemoptysis trial or the post-TNA hemorrhage trial. And so the second step for me was to use TXA, because after doing sodium bicarbonate for about 3 or 4 days, we did a bronch just to look. And what we found was bright red blood. There was hemorrhage in there. And the more hemorrhage there is, the more clot there is. The more clot there is, the more lungs will collapse and remain collapsed because those clots will not be able to be claimed. And I didn't want to go in and bronch that child and be aggressive. So instead, we decided to do TXA. Now, you might wonder, isn't TXA kind of counterintuitive? If you gave TXA, you would make more clot. And if you made more clot, you'd make the situation worse and you'd make the lungs clamp down. And that's probably true. But if we don't stop the source of bleeding, the cycle will continue without mitigation, without abating. And there's no endpoint to that. So the thought was the next 3 days after the bicarb treatments was to use inhaled TXA to stop any bleeding, because thereafter, the institution of the next therapy could potentially be abrasive and detrimental. So I wanted to make sure the airways were pristine for the next trial. So what we did next was we employed Liquivent. The idea of Liquivent actually came from Laura Ortman, who had suggested this on one of our prior prolonged ECMO patients, the one that had all the complications from hemorrhage. However, it wasn't instituted at that time, probably because we needed an emergency IND from the FDA. That would take quite a bit of coordination between the critical care group, the FDA, the pediatric research office, and that's difficult to do. It's challenging to do when you have a full service of patients. But I was lucky. I had a very good group of individuals helping me out, and we were able to get emergency use access for Liquivent. And so the time frame was I started on a Wednesday, and I started the paperwork on Wednesday. We got the paperwork in by Thursday, and by Thursday afternoon, the FDA actually FedExed us the Liquivent. It was in pharmacies' hands Friday morning. But we were not going to start it Friday morning because I wanted 5 days of instituting the bicarb and TXA treatments so that when we came in on Monday, we could do a bronch, we could reassure ourselves, and then move forward on a day-to-day basis with Liquivent. So what is Liquivent? It's also known as perflubron. It's a radio-opaque liquid. It's highly dense, denser than water, denser than oil, and denser than most of the solids that are found within the lung, debris, for example, and clots. And the way that it's supposed to work is it's supposed to circulate because it's so dense. Kind of like think about adding oil to water and shaking it. What ends up happening, or I should say adding water to oil. Say there's a container of oil and you want that oil to come straight to the top. You drop water because water is more dense than oil and it's just going to push the oil all the way to the top. And that's kind of the way Liquivent works. Liquivent is supposed to percolate down the airways, down through the distal areas, under all the debris. And as you fill up the lungs with Liquivent, it should push the debris. So it's critical that you have enough Liquivent in the system for it to work. From a side effects perspective, Liquivent has a good safety profile. It is not absorbed issues. Okay? It's not taken up by the lungs, the blood vessels, or anything. If it's ingested, it's not toxic because the radio-opaque product in Liquivent was actually used for GI imaging in the past. So it's safe. It's well tolerated. The only problem is if you use Liquivent, you may confound your lung exam, your chest x-ray for a long time because everything that Liquivent touches becomes radio opaque, even if it has been removed from the system. And how is it removed from the system? Either you can suction it out or it simply evaporates. So over a 48-hour period, all Liquivent in a lung should evaporate. Should. It is provided by a company in Texas called Origin. And as I mentioned, the FDA has to approve it. We had an approval for using it for a 5-day period, which we extended, and we received vials of Liquivent over the course of our experience. Now, to guide me in this process was a lot of help coming from experts across the country. There's about 23 different manuscripts that were written on Liquivent from the 90s all the way to the mid-2000s. However, in pediatrics, there were mostly case control studies or case reports and case series, and mostly in neonates, okay? Suffice it to say, it's not FDA approved, and the help that I got came from all of these different individuals listed from all these different universities, and they've done it on 1 to 3 patients. The leader amongst the pack was supposed to be Omar, very, very helpful, but the one that helped me the most was Kendra Smith. She was on text with me, and she was helping me figure out kind of what I was doing. The difficulty is that we had to figure out for ourselves, how would Liquivent work in this pediatric patient that was 20 kilos in weight? Whereas they've done it in neonates that are 2 to 3 kilos in weight. So the amounts in each of the protocols varied widely, and literally I had to do the experiment at the bedside to figure out how much to institute. So what I wanted to do was to show you a document that I put together of our experience with Liquivent in our patient. Okay. I think you guys should all be able to see that, correct?
Yeah, we can see it.
Okay, I see it.
Perfect. So our 5-year-old female, trisomy 18, prolonged VV ECMO. She was going on for, no, this was probably week 5, secondary to PARDS from parainfluenza pneumonia. So on day 1, which was Monday, December 7th, we started at 1:30 after having done a bronch, after reassuring ourselves that everything was fine and there was no more clear bleeding. I should have mentioned one other thing, sorry. Why was I so hung up on making sure the kid wasn't bleeding? Because if you have a fresh clot, Liquivent can potentially kind of unearth that clot and allow for bleeding to resume. And I wanted to make sure that we had several days of TXA and proper clot formation. So here we are starting our Liquivent infusion at 1:30 in the morning. We started with 8 mLs because the protocol that was given to me was for a neonate and it suggested putting 5 to 10 mLs into the lungs. So here you can see when I gave 8.5 mils that you had only this much of the lungs filling up with liquid vent. But the interesting thing is that we were able to get liquid vent all the way down to the distal airways. And that was looked at as a success. Because if you can't get it all the way down, you're not going to be able to get all the debris up. Okay. So at 2 o'clock, I put another 40 cc's in there, and I got a little bit better acceptance, if you will, of the perfluorine, but it wasn't complete. And you can see this meniscus, or rather this interface that's forming up here within the trachea. And so we decided, you know what, let's have at it. Let's put another 125 cc's in there, and boom, you've got really good acceptance now into the lungs, right? And so we empirically instilled a volume of 175 mLs until both lung fields looked like this. And how did I know that was enough? Initial 2 installations were done, and the X-ray was done right afterwards. Then what I did was I just dropped as much liquid vent as the lungs could take until I could see liquid vent rising into the endotracheal tube, which told me that there was enough in the lungs and it couldn't accept anymore. And between each installation, we actually bagged it so that it would go all the way down. And after putting 175 cc's in, even after we bagged it, it would come right back up. And we did not suction at this point, okay? And so that was the first installation. And how frequently are you supposed to do it? I was told you could do it every 4 hours throughout the day and night. Since I was putting myself in charge of this, and since we were doing this for the first time, and since we wanted to be not very aggressive, I decided we would do 3 installations a day, 8, 12, and 4, and kind of see how things went over the next 5 days. And so that was day 1. Day 2, we did a chest x-ray prior to giving any perfluorine. It has filled up the lungs, although you can see that the interface is much lower. So we suctioned and then instilled, and then suctioned and instilled, suctioned and instilled throughout the day. And at one point, she ended up having some spilling out of her nose, went in through her throat and into her stomach. But again, like I said, we confirmed that that was not going to be detrimental in any. Again, PFU interface within the trachea, filling bilateral lungs. Day 2, to me, was also a success because we had lots of perfluorine in the lungs. And whenever we took it out, we saw lots of clot, lots of debris coming out. And there are pictures of the amount of perfluorine that came out and the amount of clot material that was settling right on top. And all that stuff was coming out of the child's lungs without any fresh hemorrhage. Day 3, kind of instituted the same therapy, but I began to see that there was some signs of hyperinflation going on one side. And I was worried that one of the problems that can happen is if a lot of debris comes up and you're not suctioning it all out at the right time, it can plug up the large airways. And then you have a one-way valve where the liquid vent goes down but doesn't come up. And then you can have a liquid vent pneumothorax. And I didn't want that to happen. So, because of the hyperexpansion, I decided to keep the volumes a little bit lower. And next day, this is what I saw. And I wasn't able to instill any further liquid vent despite even suctioning whatever I could. There was some obstruction in here. And you can see that. That's not the endotracheal tube kinked. There's actually something in the endotracheal tube. And so on Thursday, we decided to do a bronch, and we found tons of debris within the lungs. But the problem was that when we went after it, she began to bleed. And we did both the flexible and rigid, and there was just too much bleeding going on in the mouth. And so we kind of said, let's stop. And we gave her a break for the next several days. We kind of just stopped instilling anything. And for the next 4 days, we gave her a break. And I was hoping during this time that the liquid vent would evaporate and that we would actually have open lungs. Unfortunately, that wasn't the case. Even if the liquid vent had done anything, her lungs kind of ended up recollapsing. We didn't see any improvement in tidal volumes. And so Laura came in after me and decided to do liquid vent just a few more times before kind of calling it failure. And we finished up the amount of liquid vent that we had and didn't see any further effect. The child continued to have ongoing bleeding diathesis. She also had a lot of other end organs that were damaged, which is why we didn't push the perfluorine on. Her liver was failing. Her kidneys had already failed. She had, essentially multi-organ dysfunction syndrome, including the lungs, the kidneys, the liver. And when you have that many organs involved, your mortality is very, very high. And so taken together, we felt that we had done everything we could for this child, and we went forward with withdrawal of mechanical support and allowed her to pass peacefully. But this was a very informative exercise that we did. because it gave us, and I don't have any other slides, so I'm going to stop sharing. But it kind of gave us many different tools in our toolkit now to be able to employ when we are kind of with our backs against the wall on a patient that gets into a prolonged ECMO duration. It also taught us what prolonged ECMO duration really is, right? From my own literature review, anything above 3 weeks now is prolonged ECMO duration, and you can see that the mortality drops to 40% from 60%. And so we really need to start having those discussions at about the 3-week mark after a patient has been on VV ECMO for PARDS. Moreover, putting a patient on VV ECMO for PARDS should be done as quickly as possible to allow the lungs to rest. And those lessons I think we've learned pretty nicely from the PARDS and prospect studies. But once a patient is on, and once those lungs are allowed to rest, and once you do see some degree of collapse, there's no reason you can't use things like bicarbonate to try and improve recruitment by removing debris. There's no reason that you can't use TXA at the first sign of pulmonary hemorrhage to try and quell that bleeding and prevent the clots from getting out of hand. And I don't think there's any reason to not use Liquivent to try and improve recruitment. But now the point is that it should be done earlier in the course of a child's disease process. So that's all I had for my presentation on adjuvant therapies for prolonged duration VV ECMO for PARDS. I'd like to open up the floor to whatever questions you guys might have.
Sid, this is Rachel. So I don't know. This is probably before your time, as maybe in fellowship, maybe. Dennis may have been the only other person I think that's probably been around as long as me. We used to use diluted bicarb to suction with for kids that had like really thick secretions. So we did that routinely when I was a new nurse way back many years ago. So I hope that maybe with this, and not just in kids that are on ECMO, I mean, I think that might be beneficial. I don't know what you think about as far as beneficial for other children that you're having trouble with debris removal and all those kinds of things, or just really thick mucus. What we used to do in the old days was we would take 3 cc's of 8.4% bicarb and 7 cc's of saline and mix it in a 10 cc syringe and literally like use it to lavage and then suction. So I don't know what your thoughts are about that.
I would. So I've seen it used in fellowship by one of my co-fellows in a kid that was deteriorating on the vent. And I asked the question, why are you using bicarb? And he said, oh, it works like beautifully. And I don't know why we don't use it. It's just not something we use. We talk about N-acetylcysteine, not as much, 3% hypertonic saline. All of these things have come, but I don't know why bicarb has fallen out of favor. If there's literature there that I haven't read or I don't know of, I'd love to read it. But in my opinion, given the biochemical properties of bicarb and how safe it is, there should be no reason we can't use it. It's also not an agent that causes bronchospasm like NAC and 3% do. So I don't see why we can't use it more frequently. And the RTs on the chat can inform us if we are mistaken, or can inform us of why we're not using it, or why these other products, which again haven't been shown to be very clinically efficacious, are being used over bicarb, which I think is probably the cheapest of everything.
This is Dennis. In my experience, Rachel's absolutely right. It's something that kind of fell out of vogue some years ago, and what is old has become new again, I suppose. I don't have a better explanation for it than that.
It's kind of like digoxin making its rounds back in our ICU.
That's true. We had a kid, and I don't know, I didn't see Jeff Solomon on this call, but I worked with him when he was a first-year fellow in St. Louis, and we had an older attending, and I brought that up to her, and she's like, I don't know why we don't do that anymore. And anyway, we ended up using it for a particular patient that had really bad pneumonia, and we had really good success, and the patient did well.
There we go. Yeah, I don't see why we can't bring it back. There's no data against it. I have some data for it. I'd be for it.
So this is Dennis. I have two questions.
Mhm.
First of all, they're both about the Liquivent. First of all, you said that the Liquivent came from the FDA.
Mhm.
Is that something that the Children's Hospital had to purchase, or was it the government just gave it to us?
Good question. So we actually purchased it from the company Origin in Texas after FDA approval. I requested that the hospital cover the charges because it was an experimental therapy, and there's no reason that a mother should have to pay for an experimental therapy that we don't know it's going to work, right? So the hospital swallowed the cost. It costs $400 for a 50 cc syringe. So and there's I think 8 syringes, no, 10 syringes that come in a box. And so I was kind of, I don't know why you guys laugh at me though. I was worried that I don't want to waste all this money. And so I was ordering it like 1 box at a time, where I should just order 10 boxes, considering things like pentobarb that we order, like there's no one's business. But anyway.
My second question is, even though the team deemed this quote unquote failure, do you plan to publish any kind of like case study on this at all, or add this to the literature?
Yeah, I would like to, but I'm not sure how to go about it, because yeah, I would like to, but I don't know how to go about it. So there's been a request from the brain group that I was talking to publish our protocol. And it might just be that we publish a protocol of how we did it and show the chest x-rays and kind of what was being done. My only concern is, what are we showing? We're showing the one case in a 20-kilo kid that we were able to get the profublon into her, but we don't actually have an endpoint, or we have an endpoint, she died, and we don't actually have a good effect, meaning the lungs didn't really open up. So even if I publish it, the question is, if somebody like me looked at it and looked at that and said, we did all this stuff, lungs didn't open, she died, I'd be like, I'm not really going to end up using this protocol because I don't see any potential success in it. So I don't know what angle to use to try to get this out there, but there has been a request to get it out there. I just have to figure out how to get it out there.
Sid, I know there's been a lot of discussion, at least between ECMO specialists and whatnot. I mean, we're the ones that sit in there every day, weeks at a time, and all that sort of stuff. But what are your thoughts about what if we had instituted this sooner? My other question to that is, she was extubated fairly early on, and then they had trouble getting a tube back in her. So this is just a thought that I had, was if we had just left her ET tube in and just not had it connected to anything. Like I said, we can what if ourselves to death for sure, but
Yeah.
I'm just thinking that maybe going forward and other patients that might need us, would that be something to consider?
I see what you're saying. You're saying that instead of extubating and liberating her from the tube, just liberate her from the ventilator and leave the tube in there.
Exactly.
Yeah. Most of these studies on extubating these patients is to try and get the sedation down, wake them up. But there's a population of pediatric patients that you cannot do that on. And it's those kids that are under a certain age developmentally that will not sit still. And they'll grab at the ECMO circuit and then grab at this, grab at that. So extubating those patients won't work to get to the endpoint of reduction of sedation and all that. But with the fact that I think we had success in the installation of Liquivent, I think, yes, it should be done earlier, or it could be considered early. Like I said, we were at the 5-week mark here by the time we did it, right? We should have been at the 3-week mark. That could have helped. Anytime earlier than that, and I think most of my partners will say, why don't you wait until, and I would agree, why don't you wait until the PARDS gets better? In my opinion, what we do is we have a kid on ECMO at the 7-day mark. We're having the first conversation. Okay, what's our game plan at the 2-week mark, right? They were talking about that at 1 week. When the 2-week mark hits, we say, we've had this discussion a week ago. Our game plan at the 2-week mark was, well, let's start to get some of these other therapies going. Okay, and then at the 3-week mark, if we're not out, we'll do something like Liquivent and see what happens. And that way we have a structured approach that stays within a reasonable period of time for these patients. I think the problem is that we didn't really have anything like this prior. And now that we do, I hope we would be able to utilize it moving forward. Because I think we'll all agree that the Liquivent was proven to be safe. I can't say it was efficacious because we didn't get the lungs open, but it was at least safe. And so as far as having something in your toolkit to try and use, this is going to be better than bronchoscopies and recruitment when the lungs aren't ready.
The other thing that I have heard come up from lots of different people, bedside nurses, not just the ECMO team, but was the fact that she was a trisomy 18.
Mm-hmm.
My personal thought, I mean, this is just the way I think about it, is up until this, she was in her normal state of health. It's not like she was basically going downhill. She was already like having multi-system organ failure, things like that. So I like I said, I've heard this from a lot of people, and I just wondered, and there may not be any research out there as far as kids that have baseline maybe genetic abnormalities or other things. I mean, obviously, if you have BPD, I mean, that's a whole different situation because that's baseline lung disease, and that doesn't really apply in this case.
No.
The other thing I was wondering was she ever discussed for a potential candidate for the prospect study? I know you kind of helped run that. So
She was. I was afraid that we missed the ball on her, but she had enough underlying abnormalities that disqualified her. I can't remember what it was, but I remember Andrea and I having that conversation about her and it ending up disqualifying her.
Thanks, because I'm not very well versed on the prospect study, so I just wondered if she had been discussed for that.
I think what she had, didn't she come in with a home oxygen requirement or something, like either that or she had neuromuscular weakness, something along those lines.
Well, I think the neuromuscular weakness is probably, that may very well have been it, because I don't think she was on baseline oxygen.
Yeah, I think you're
right. Previously to coming in, being sick like this.
Yeah, I think it was the neuromuscular weakness, which is why we that was one of the exclusion criteria.
I think sometimes mom said that she was like on a 1/2 liter of nasal cannula at home, but I would say that she was probably like wheelchair bound. So
yeah, I wasn't there in the earliest part of her stay before ECMO. I'm not, and I think she did spend some time intubated prior to ECMO, if I'm not mistaken. And I'm not sure if during that time she was paralyzed, prone, and all of those parameters used like we would on Prospect to help these kids and be really, really aggressive. My point is, in PARDS, you have to be aggressive to rest those lungs. You have to aggressively rest those lungs, which means do everything you can right up front to get your protective parameters and then sit back and watch. If it doesn't work, then pull the trigger for ECMO early. So I'm not really sure what the trajectory was prior to ECMO for her, because that could have played into how sick her lungs got.
Well, that's the other thing, because I know when she came over this was when they were still over physically in PQ South.
South, right?
I know when she came over that her OI the first night was like 26.
Yeah.
And that was just at the baseline, because I think I was over in PQ South or something that night, but I calculated it and I was like, well, we need to think about, but I as far as I know, I don't think she was prone or some of the other things that I know you guys do with the prospect study.
Yeah. It's almost a blessing and a curse to have this prospect study, right? You have it when a kid qualifies, it's like all our guns are blazing on these kiddos. But if we don't qualify, we fall back on whatever the flavor of the day is. And I've tried to push that even if these kids don't qualify, if they have OIs that are that high, they should still have a number of those treatments prescribed. The caveat is that the prospect study is testing those therapies. So I cannot push them in all good conscience. I can just suggest and recommend.
Hey, Cindy, Peggy.
Hey.
I was there the day that she was cannulated, and I know all morning, like, she was needing increased oxygen needs. She was on a PEEP of like 14 or 16, and they were talking about proning her, and then they just decided not to do that, to put her on ECMO. So that was in discussion of starting to prone and figuring out a different.
Yeah, and I would agree if all of these therapies again are supposed to buy you time and buy the lungs time to see if they plateau and get better. And if you feel like kind of the kid is deteriorating rapidly, then just rest those lungs with VV ECMO better than trying to do all these other therapies that could potentially lead to more detriment.
This is Lindsay Cleaver. I was in house the night that she transferred from South to PICU North, and I just wonder. Dr. Carty was the doc on that night, so I wonder in some of these scenarios, having those locums care for some of these patients, if that complicates, the decision-making process, going forward.
It may, except for the fact that now we've had the same locums working with us for almost 2 years now. They know how we function. They know that we're an ECMO heavy center and that we pull the trigger early. So I can't speak to that. But I also hope that the APPs are kind of speaking up and or asking for second opinions if they disagree, which I know they have. So that's my hope. But we haven't had a formal discussion of when to kind of pull the trigger on these things because, like you saw in my presentation, there are no inclusion exclusion criteria unless we come up with them in our institution. And since we don't have those, it's hard to tell them what to do when we don't know what we're doing ourselves, and it becomes kind of a day-to-day thing.
Yeah, and I don't remember the time frame between when she transferred from south to north and when she was cannulated. But I know that obviously the reason we did it was because we were having those discussions about ECMO. So I don't know why they decided not to do it at that point, but just a thought.
Yeah. You know, one of the things that we didn't really figure out in her is why was she bleeding as much as she was? Why were her lungs affected the way they were? You know, not lungs, sorry, liver. She went on with isolated lung disease, so isolated organ failure, and then it just kind of unraveled. And I remember instituting things like IVIG, as well as high dose steroids, to try and quell any kind of an inflammatory process with, I thought, success, because during that time, her bleeding got much better, her lungs looked much better. But then they got out of hand again. And every time we changed the circuit, she would get inflamed again, and inflamed to a point of, rampant bleeding and all of these things. And it happened on multiple ECMO change rounds. And then I don't know if she ended up going through plasmapheresis or not, or another course of steroids and IVIG, but there was something underlying, I think, that was causing these issues. And one of the pieces of advice that I received was that if you haven't controlled the underlying problem, the liquid's not going to do anything, because that underlying problem is going to continue to cause problems. And I think that's what ended up happening with her, that whatever was going on underneath it all, we didn't get a hold of. And so that's what ended up claiming her life.
And another discussion that has come up was the cannula that was chosen that she was cannulated with, because that cannula was, for her body habitus, was way too long from what is normal. That cannula was really deep the entire time. And I mean, I just can't help but think is how could that have potentially affected her liver, because she didn't have any baseline liver dysfunction to begin with.
Right. And the thought is whether the jet stream from the ECMO circuit was actually causing liver injury, direct liver injury.
So I guess, obviously there's obviously maybe a different forum for this discussion, is that maybe she should have been cannulated in a different way.
Mm-hmm.
So this is
Rachel, I was going to ask that same question. I see Mindy is on here. I don't know, Mindy, if you have any thoughts to that, but I had the same, questions in my mind.
So guys, this is Dennis. I actually have her assigned as my case review for this month, and there's a short list of pretty important topics that we want to talk about together as a team on this one. And cannulation and cannula selection certainly is near the top of the list on my questions to review with the whole group on Wednesday morning.
Great.
I was not there to cannulate, but I believe she was cannulated with the 20 VV, and that one is just a little bit longer than the 19, and because of her stature, that definitely could have been a problem. I know we had discussed about doing dual site, but at that time she had a lot of hemodynamic instability. She, at that point, was very high on inotropes, and I was discussing with Dr. Fuller, and she just felt like at that time it was probably not a great or safe decision to convert. So it was an ongoing thing, but I definitely think we should go back and look at the x-rays to decide if liver congestion was a big part of this. It was a big concern from perfusion standpoint, and we had thought that either it needed to be pulled back or at a point changed.
Then I don't know if you'll be available on Wednesday morning for case reviews, but we'd love for you to be a part of that, since you kind of spearheaded this type thing.
Which Wednesday is it on the 20th?
20th at 7:30.
I will be available for probably 30 minutes.
Okay, well that'd be great. I mean, we'd just be happy to have you for whatever time you can be there.
Could you send me the link? Or somebody send me the link.
Yeah, we'll have somebody send it to you.
I'd be happy.
Oh my, did we have in the discussion? He's already smarter at ECMO. This is great.
Yeah, he's maybe not the best at paying attention, but he heard some fabulous information. So
About the osmosis.
anyway. I wanted to thank you, Sid. This was great. I think everybody really enjoyed this, and we'll have to talk to you more for education in the future.
My pleasure. And I thank you guys for engaging us in a good 20-minute discussion. That was really, I think, a very good part of this discussion. And, you get as much out of it as you put in. So thank you guys for that.
Thank you so much.
Good. We appreciate it.
Thank you.
Yeah,
Thanks, guys.
and I did report it, so thank you.
Okay, take care.
Have a good evening.